Welcome to our video on fetal growth restriction, macrosomia, and amniotic fluid disorders. Let's get started. So fetal growth restriction is fetal weight less than the 10th percentile for gestational age. And there are actually two types of this. There's symmetric and asymmetric. Symmetric growth restriction affects all body parts and all organ systems equally, whereas asymmetric spares the head. So keep this head idea in the back of your mind and we'll come back to it. Okay, so symmetric fetal growth restriction usually occurs in the first trimester, and this is either due to chromosomal abnormalities, such as aneuploidy, or congenital infections. On the other hand, asymmetric, that is head-sparing fetal growth restriction, occurs in the second or third trimester, and this is usually due to any cause of uteral placental insufficiency. For example, diabetes, gestational hypertension, or preeclampsia. And maternal malnutrition can also cause asymmetric fetal growth restriction. Here we see the newborn with symmetric and a newborn with asymmetric fetal growth restriction. On the right illustration, you can hopefully appreciate the relatively large size of the fetal head compared to the body. On the left, however, you can see a proportionately small fetus. So again, when you think of asymmetric growth restriction, just think about the head as being the only thing that's spared, but the whole body shrinks. So it's not really symmetric. Moving on to management of the fetal growth restriction. Once fetal growth restriction is diagnosed, then we should perform weekly biophysical profiles to ensure that the fetus is doing well, and then you can assess the possible need for emergent delivery. And serial umbilical artery Doppler ultrasounds actually help us evaluate the umbilical artery blood flow in the fetus. And if that blood flow is decreased or absent, or there's reversed end diastolic umbilical artery blood flow, then that indicates imminent fetal demise. So that's not a good thing. And we talk about this idea of ultrasound of the umbilical artery and reversed end diastolic blood flow in a different lecture. So we're not going to go into that anymore now, but if you'd like more information on that, you can just go review that other lecture. For the purpose of this lecture, just know that you're trying to use ultrasound to assess the growth of the fetus. Okay, now let's talk about fetal macrosomia. Fetal macrosomia is when the newborn weighs more than 4 kilograms. And the signs that are suspicious of fetal macrosomia are a large fundal height and polyhydramnios. So let's explain why this is the case. Okay, so fundal height is the distance from the symphysis pubis to the uterine fundus. And macrosomic babies usually have longer than normal height that contributes to an increased fundal height. So basically you get a taller baby in the uterus, making the fundal height larger. Now, as for the amniotic fluid volume, this is roughly proportional to fetal size. In other words, the larger the fetus, the more urine the fetus will produce. So this is why fetal macrosomia is often accompanied by polyhydramnios. Let's now concentrate on the risk factors for fetal macrosomia. So maternal diabetes is one of the most common risk factors for this condition. And the reason why maternal diabetes can cause fetal macrosomia is that maternal hyperglycemia causes fetal hyperinsulinemia. So that makes sense. If the fetus is getting exposed to more glucose, then it's going to produce more insulin. And that insulin, in turn, increases lipid and carbohydrate deposition in the tissues. So that increases the overall size of the baby. Other risk factors include pregestational obesity. In other words, the mother is obese prior to even becoming pregnant, and also if they gain a lot of weight or excessive weight during pregnancy. Those are also well-documented risk factors. Additionally, possibly the most intuitive risk factor is that if the mother had a prior macrosomic baby. So that makes sense. If you've had one super big baby, the risk that your next baby will be super big as well is higher. Interestingly, if the maternal age is greater than 35 years old, then she's also at risk of having a macrosomic baby. Now let's do a question to apply what you've learned so far. A 32-year-old G3P2 female comes to the physician at 36 weeks of gestation for a routine prenatal visit. She gained 12 kilograms during her current pregnancy. Her pre-pregnancy BMI was 23. Past medical history is significant for gestational diabetes mellitus. Ultrasound reveals a large baby with the amniotic fluid index of 28 centimeters. Which aspect of this patient's history contributed the most to fetal macrosomia? So feel free to pause the video while you consider this question. Okay, so we've got a 32-year-old female with a past medical history of gestational diabetes, gained 12 kilograms during pregnancy, and the ultrasound reveals a large baby and polyhydramnios. And just as a review, polyhydramnios is when the amniotic fluid index is greater than 24 centimeters. So at 28 centimeters, this qualifies as polyhydramnios. Okay, now the greatest risk factor here is her gestational diabetes. So as we explained on the previous slide, maternal diabetes causes fetal hyperinsulinemia, and that in turn results in excessive fat and glycogen deposition into the fetal tissues. And the patient's age isn't a contributing factor here because she's only 32. And the age at which macrosomia is more likely is 35 or older. But what about her pre-pregnancy weight? Well, her BMI was 23, which is a normal weight. So she didn't have excessive weight pre-pregnancy. And then during pregnancy, she didn't gain too much weight either. She gained 12 kilograms. So that's actually normal. So again, the thing that contributed most to macrosomia is the gestational diabetes. Moving on to diagnosis. We can diagnose a baby with macrosomia either via prenatal near-term ultrasound or postnatal weight measurement, which makes sense. You can either visualize it before they're born, or when they're born, you see, wow, that's a large baby. Then you can say, okay, this is a macrosomic baby. And as we already mentioned, macrosomia is a neonatal weight greater than 4 kilograms. Now, as for prevention, control of maternal diabetes and gestational weight gain and regular exercise is the key. In other words, if the mother is compliant with her anti-diabetic therapy, then the fetus will be exposed to less glucose, so less fetal insulin will be produced. Regular exercise, on the other hand, will prevent the pregnant woman from gaining excessive weight, which itself is a risk factor for fetal macrosomia. So now let's talk about amniotic fluid disorders. But before we dive in, let's first remind ourselves of normal amniotic fluid circulation. So amniotic fluid is mostly derived from fetal urine. However, small amounts of amniotic fluid also come from expelled fetal lung fluid. But considering that amniotic fluid is mainly fetal urine, then renal disorders or placental insufficiency from conditions like hypertension and preeclampsia can actually cause decreased amniotic fluid production. So now let's talk about the resorption of amniotic fluid, because obviously it has to go somewhere, or else the fetus would just urinate and the amniotic sac would just get bigger and bigger. But obviously that doesn't happen. Now, amniotic fluid is removed mostly via fetal swallowing, but some of it is also reabsorbed by the amniotic cells as well. Therefore, any congenital condition that causes gastrointestinal obstruction or any neurological conditions that impair fetal swallowing and that swallowing reflex can actually decrease amniotic fluid resorption. Now, here's an illustration of normal amniotic fluid circulation. This green arrow indicates swallowing of the amniotic fluid, while the red arrows indicate urine production and amniotic fluid absorption via the gestational membranes. Now let's talk about the disorders, starting with polyhydramnios. So esophageal and duodenal atresia can both result in polyhydramnios due to decreased amniotic fluid resorption from the GI tract. And that makes sense. If the fetus can't swallow the fluid, then it's just going to build up, causing polyhydramnios. Now, anencephaly, a type of neural tube defect, causes impaired fetal swallowing, so the amniotic fluid is also retained in the amniotic cavity. Maternal diabetes causes fetal hyperglycemia because that glucose crosses the placenta, and that glucose filtered through the fetal glomeruli causes osmotic diuresis and increases amniotic fluid production. And this is interesting. That means by virtue of the glucose in the urine alone, it's enough to cause polyhydramnios. Now, fetal anemia results in a compensatory increase in cardiac output, which in turn increases GFR. And that increased GFR causes increased urine production. And finally, multiple gestations can also cause polyhydramnios. Simply put, the more fetuses that there are in the uterus, the more urine that they will produce together. And just as a brief review, this is a fetus with anencephaly. So pay attention to that relatively large size of the fetal eyes and compare that to its head and the missing parts of the skull. So if the fetus has this condition, then they're not going to be swallowing fluid, and the amniotic fluid will just build up in the amniotic sac, causing polyhydramnios. Shifting gears here, let's talk about oligohydramnios. So maternal hypertension, either pre-existing or starting at gestation, can cause oligohydramnios. So the idea here is that less fluid or blood is being transferred from the mother to the fetus. So that means that the fetus will actually put out less urine. So there will be less fluid in the amniotic sac. Now, bilateral renal agenesis is another potential cause of oligohydramnios. And that makes sense. If there's no kidneys, then there will be almost no urine production, so there will be very little amniotic fluid. Now, as for posterior urethral valves, although the fetus does have kidneys, even in this condition, there's actually an obstruction of urine outflow. and this is at the bladder neck. And so this results in decreased amniotic fluid because less is getting to the amniotic sac. Now, severe oligohydramnios can cause Potter sequence. Potter sequence is when the fetus is compressed against the amnion due to the small amounts of amniotic fluid. And here we're reminded of the fact that that amniotic fluid is really a cushion and protection to the fetus. And without it, they just get squished and compressed. Also, since that amniotic fluid aspiration, basically the fetus inhaling that amniotic fluid, is necessary for proper lung development, that means that Potter sequence can also result in pulmonary hypoplasia. And that's actually the most common cause of death in these babies. And then once again, since the fetus is getting compressed, they can have things like facial defects and retrognathia, low set ears, and a flattened nose, just the consequence of being squished while growing. And also, they'll have extremity defects, so their arms will be squished and contorted, and legs. Here we see an image of a newborn with Potter sequence. And hopefully you can appreciate that flattened nose, the abnormal shape of the head, and the limb defects. And that concludes our section on fetal growth restriction, macrosomia, and amniotic fluid disorders.